So it is now my great pleasure to introduce Dr. Manon Lounnas, researcher in global health and ecology at IRD. She's science officer at PREZODE International and science officer for the PREACTS program. Dr. Lounnas will introduce today's topic and guide us through the discussion. Thank you all, and over to you, Manon.
Thank you so much, Elsa. So I will just share my screen and put in presentation mode. Okay, can you see it well?
Yes, we can see it.
Okay, perfect. Okay, so good morning and good afternoon, everyone, and thank you so much for joining us today. So we are really excited to dive into this important conversation about community-based and integrated surveillance systems and how they can help us prevent the emergence of zoonotic diseases. So the past few years have taught us that early detection and rapid responses are absolutely key, not just for protecting human and animal health, but also for preserving the ecosystem we all rely on. And yet there is still a big gap, the gap between what's happening on the ground in communities and when that information finally reaches public health and veterinary services. So that's the challenge we are here to explore together today. And on this topic, I invite you to read the very recently published article by Wasletongs et al. In the Lancet Infectious Diseases, where the authors propose a step-by-step framework for effectively integrating community-based zoonotic disease surveillance. And so this proposed framework directly aligns with what PREZODE, through its operational program PREACTS, aims to advance. And community-based surveillance isn't just about collecting information, it's about empowering the people closest to the risk to take an active role in protecting their health and their ecosystems. And when these local efforts are connected to national and international systems, they become powerful, forming truly integrated surveillance that brings together data, expertise, and technology across sectors under a One Health approach. So by combining community monitoring with advanced tools and data, we can build resilient networks that detect emerging zoonotic diseases early and guide smarter and long-term prevention. So today's session will explore these issues through complementary perspectives. Together, we will consider what are the key elements of community-based surveillance, which measures help ensure the sustainability of integrated surveillance, and how can tools and technologies bridge gaps between sectors to improve our collective preparedness. To address these topics and present solutions, we are very honored to welcome 4 experts. So Dr. Rado Rakotonanahary and Dr. Finnegan, researchers at the NGO PIVO, who will present the development of e-health solution to enhance community-based surveillance in Madagascar. And Dr. Diego Montecino and Dr. Paulo Colchao, data scientist with the Wildlife Conservation Society, will share insight on the SMART for Spatial Monitoring and Reporting Tool model, a tool designed for integration with other key technologies. And they will present a case study focusing on activities in Peru following a global overview. So we are excited for the opportunity to learn from their experiences and explore how integrated surveillance systems can become a cornerstone of One Health strategy worldwide. Just before we listen to our speakers, I will take 2 minutes to introduce the PREACTS program, that is PREZODE in Action in the Global South. And this program is developed under the umbrella of the PREZODE initiative. And in this program, we are deploying the solutions that will be presented to you by our 4 experts. So the PREACT program is divided in 3 phases, and the 2 first phases have been launched, AFRICAM, ASAMCO, and the third one is ASICA. And so the program is constructed basically on the pillar of PREZODE, understanding the risk, reducing the risk, monitoring the risk, and we have a cross-cutting work package on policy science society dialogue, on gender and ethic aspects, and on trainings. And so we have a lot of activities on community-based surveillance, where we are joining activities from Work Package 4 and Work Package 3. And we are, of course, constructing those community-based surveillance on information provided by the first two work packages. So in AFRICAM, AFRICAM is deployed in Senegal, Guinea, Cameroon, Madagascar, and Cambodia. And we have, for example, in Senegal, the development of an integrated information system. In Guinea, we have the development of a community-based surveillance system. In Cambodia, a surveillance system based on the local needs and constraints. And in Madagascar, that will be presented by Karen and Rado. And on the second phase, the ASAMCO project is deployed in Latin America, in Democratic Republic of the Congo, and in Laos and Thailand. And we are also developing activities on participatory protocol for prevention and monitoring plan, developing digital platform for information. We are conducting community training for surveillance, and we are also deploying the smart surveillance system in Laos. So thank you so much for your attention. And now I will leave the floor to our four experts, starting with Rado and Karen. So the floor is yours, and I wish you a very nice webinar. Thank you.
Thank you. I will begin sharing my screen. Does this look okay?
Yes, perfect.
Great, thank you. Radu and I are here today to talk about building community surveillance systems in Madagascar for public health and research. And Radu will talk primarily about the project, but I'd like to start by giving a brief orientation to Pivot and our work in Madagascar. Pivot began in 2014 in Madagascar. We began work in one district, Ifanadine district of the Vatovavi region. And in 2024 began the process of expanding from one district to all three districts of Vatovavi. We work with the Ministry of Public Health of Madagascar to strengthen the public health system and support nearly 1 million people across Vatovavi. Pivot combines implementation, care delivery in the public health system with science and innovation through Pivot Science. Pivot Science is our research and innovation arm. We work to develop a district-level model health system as part of the public health system with the Ministry of Public Health of Madagascar. And the model health system works across the 3 levels of care. There are community health sites staffed by community health workers, which are spread across the district and the region, and indeed the country. There are primary care health centers, which provide essential primary health care services. And then there is a district hospital providing secondary care. This is part of a larger health system where patients are referred to tertiary care hospitals for more advanced services. The district health system collects data, which Radu will talk about in detail. And at the base of this pyramid, providing essential primary care services, are community health workers. Pivot supports more than 1,600 community health workers across Vatovavi region. As part of this, they've been recruited, trained, supervised, and compensated, and trained in digital health data collection, which Radu will talk about in detail. These community health workers, as part of the health system, are providing essential information about the care that they are providing across the remote communities of Vatovavi region, data which is essential both for research and for public health activities. I'll now turn it over to Radu.
Thank you, Karen. So, as Manon Lounnas has told earlier, AFRICAM is a multi-country project in the PREZODE international initiative. AFRICAM Madagascar, next slide, please. AFRICAM Madagascar is an implementation project aiming to develop and strengthen surveillance capacities for emerging zoonotic diseases including plague, rabies, and many others. In Madagascar, the project is conducted in 2 pilot sites, which are Ifanatina district and Murundava district. African Madagascar is split in 3 main components or packages according to each of these specific aims. The first component focuses on epidemiological survey and lab-based work in order to assess the zoonotic risks. Then the second component uses co-construction of strategies to mitigate these risks, as well as develop prevention approach. And finally, the third component has an emphasis on implementation of an integrated community-based surveillance system. For the rest of this presentation, we will focus on the third work package of Africa Madagascar that PREZODE is leading in Ifanatina district. PREZODE and some partners of Ministry of Public Health has been working to strengthen daily work of community health workers with e-health records since 2019. Before African project, community health workers already conducted human health surveillance as part of their work using paper forms, which of course present challenge in terms of rapidity of information circuit and obviously the response to any possible emergence of zoonotic disease. Through the third work package of Africa Madagascar, there are several steps or activities that we have conducted. The first step was realized through a workshop with all stakeholders in human, animal, and environmental health in order to brainstorm altogether about an integrated surveillance system and also to define the key signals to be notified. Across this step, all actors agreed on 12 major reportable events in the community and for each sector. As examples of these signals, human health considers sudden clustered human deaths occurring in the same community within a 1 week period, or bites inflicted on human by warm-blooded animal. For animal health, it could be the observation of a series of abortions among ruminants in the same locality, or maybe any unexplained animal death, rats or birds. Regarding to environmental health, alert could be considered the observation of multiple fire or the perception of unusual odor around the factory. As I've told earlier, community health worker daily work was improved by the use of ComCare app for their report. So the second step of this surveillance system was about technical training by Timaki for PREZODE and Ministry of Public Health actors to allow the development of an integrated surveillance module within the ComCare application. Step 3 consisted on training for end users on the surveillance module of ComCare application. And it was also essential to tell all actors and stakeholders the information circuit for each of the health system level, of course, from the community to the district. This e-health surveillance tool is expected to accelerate the notification of alert and information circuit to have an effective early warning system for emerging zoonotic disease. Now, community health workers collect data using electronic tool for surveillance event, making the process faster and easier. In the context of a low resource setting, and rural pilot area. The notification system was also has also been adapted um, so that the alert could be transmitted using a simple phone for the actors who are not equipped with smartphone. Finally, as we aim to integrate surveillance of zoonotic diseases across all sectors, it is important to develop an interoperability layer regarding all the platform and tools. So through the different surveillance area, there are several tools used. For example, ComCare used by community health workers and the health centers responsible, and also district focal point. ComCare application or SMS for the veterinarian, the vaccination agent, and animal health, community health worker. Smart is used by rangers for monitoring of wild fauna mortality and also by field agent for the participatory ecological monitoring. So all of these data and platforms should be integrated. That's why an interoperability layer is developed to be able to allow sorry, to visualize all the data in a dashboard within the HIS2, which is the main health management information system used by Ministry of Public Health. So these are the work that we've conducted through the third work package of Africa Madagascar. We are thankful to the founder of African Project and also all involved institutions and collaborators. Thank you for your attention.
Thank you very much for this first presentation, Karen and Rad, which was amazing, very simply explained. While it's not so simple, I believe, to implement that in the field. So we will take the question at the end of the webinar, and now we will move to, I think, Diego, you are the next one.
Yes,
Yeah,
thanks.
okay. So Diego, the floor is yours.
Okay, hello everyone. Thank you for your interest to be here listening to us and our experience with working with communities for improving or extending or expanding wildlife health surveillance. I'm going to talk about the process that we have carried out for about 3 years integrating rangers for wildlife health monitoring. And I'll start with this brief introduction where to the left we can see a map of the human footprint in South America in orange red, and the polygons of the protected areas in green. So as you can see, there is a pressure on these protected areas from humans, which actually leads to interfaces between humans, wildlife, and domestic animals. These interfaces, of course, favor the spillover of diseases between these populations. And for example, from the side of zoonotic diseases, we have in the middle an example of an outbreak of Ebola in Congo that was limited by itself. So in this case, the iteration allowed that only few individuals were infected and some of them died. But depending on what is the nature or the stochastic processes behind the epidemic, we might have a spread from the natural areas into urban areas or rural areas and get a transboundary outbreak or epidemic as we saw some years ago of Ebola. However, the interfaces also provide an opportunity for wildlife to be harmed. So they can, in the broad sense of the understanding of what a disease is, wildlife can be exposed to pathogens or physical and chemical hazards, which can harm them, especially coming from people and livestock. So in the first case, I have the snares on the left, where it's a crisis in Southeast Asia. In the middle, I have the example of the screwworm, which was eradicated from Central America and North America, but it started to make its return. And now, actually, this week, there is, well, the last case that is 100 kilometers away from the border with the United States and Mexico. That is, we reported cases in dantas, birds, and pumas, actually. And on the right, that shows wild bovid, which is called banteng in Southeast Asia, suffering of a disease called lumpy skin disease, which is a virus that spilled over from domestic animals that were inside of the protected area. These species is critically endangered. Now, we do have wildlife health surveillance to understand what are the impacts and also trigger responses if evaluated as a good measure. So we can respond, we can adapt, or we can accept. However, this is the reality of wildlife health surveillance in the world. There are two publications that identify almost exactly the same answer, where half of the countries report that there is no functional wildlife health surveillance program. And when there is, 83% of these programs reported gaps in operations, coordination, scopes, or capacity. So the question is, how can we start solving this problem and expand wildlife health surveillance in protected areas and surroundings, given that they are a key interface for the spillover of pathogens among these populations that I already mentioned, but also for the exposure to hazards, physical and chemical, for wildlife? Well, one of the potential ideas is, why don't we start leveraging resources that are already in place? So from that perspective, rangers are an incredible resource because, as I said, as I mentioned there are about 300,000 rangers currently estimated that are patrolling protected areas globally. That means hundreds of thousands of kilometers and thousands of square kilometers covered on a yearly basis by these rangers. And actually, the authors of this paper say that there has to be an expansion of 1.5 million rangers if we want to protect the 30% of the planet by 2030. In the graph that I'm showing on the right, it's a publication where we survey protected areas globally, and we confirm that actually rangers during their patrols do find injured, sick, and dead individuals in different frequencies. However, that doesn't mean that encountering those animals, that the data from those individuals is actually recorded. So it's information that is being lost. And in the second layer, if they are recorded, the way that those animals are documented is very heterogeneous across protected areas, dificulting the data management and the data analysis of those information. So the challenge is how to integrate rangers in wildlife health monitoring without adding more workload, and how can they record wildlife health events, and how can they do that using a standardized protocol. So I'm going to talk about the integration of rangers in wildlife health monitoring, as I mentioned. First of all, we are supporting in technology already available for rangers. So I'm talking about the spatial monitoring and reporting tool. This is a set of tools, of digital tools that are designed to support the management of protected areas and are currently distributed in more than 1,000 protected areas in more than 100 countries. So it's very popular and has been very successful. It has three components. The first one right here is a smart desktop, which is a computer desktop software. It's a computer software whose critical unit is a database. And in that database, it manages the information of protected area. But it also allows to construct questionnaires or surveys that are then digitalized and inserted in mobile devices through the Smart Mobile application. So I can construct there is a flexibility to construct a questionnaire in a smart desktop and then move that questionnaire into a smart mobile, so rangers can actually use the smart devices and start recording information in the field in real time. These two pieces can be connected through cables, but also wirelessly through a Smart Connect, which is a server that also backs up the databases. So long story short, we can actually create a questionnaire, move it to a smartphone, and take advantage of the rangers that when they are monitoring the protected areas for different reasons. So because the tool is already available for rangers in the field, there isn't the need to actually insert the technology first, and that saves us a lot of time. So we have the resource, the human resource, rangers. We have the technology, smart, and we took advantage of that scenario to actually build a questionnaire, a standardized questionnaire to record wildlife health events, meaning more wildlife morbidity and mortality that is found by the rangers during their patrols. Based on continuous and looping feedback, we created what we're calling a Smart for Health, which is just a set of standard attributes and options for recording wildlife morbidity and mortality. And once we completed this step, we start working with local key partners that are associated with the rangers. For example, the National Park Services of Guatemala, Peru, Madagascar, and Cambodia so far. And together, what we did was to modify, of course, train them to learn how to use Smart for Health or how to record these wildlife health events using this tool. But then together, we modified the local data model. So because they were already working with SMART in those protected areas, they already have a questionnaire. And what we did was to complement the current local questionnaire with the attributes to record wildlife health events that we have in the standardized survey form or in the standardized form. And once that process was completed with the partners locally, trainers are conducted locally by the local partners with the rangers, so they can also learn how to use this tool, the modified questionnaire, in order to identify health events first and then record them using this tool. So this is the standardized form, the questionnaire. This is the questionnaire that we insert in local forms in a SMART. So it has three main components. One is to record wildlife. The next one is to record livestock individuals. And the next category or main group of attributes is to describe anything in the environment that might be associated with, that could be important or relevant for health. Okay, so I'm going to show the example when we open the wildlife category. This is what the rangers would see if they don't have any other attributes associated with other types of monitoring, right? The first one is, of course, to record the species. The next one is to record the context in which the species is found. So the individuals are recorded at the species level. And the context means it might be found hunted or it might be found in a free-ranging state. Then we have the number of animals split or categorized by health status. And when they only find healthy animals, or they want to record wildlife that is just healthy, which is going to be most of the cases, then they just need to report this number and add a 0 and 0 for the sick individuals, and that would close the observation. But when the actually more than at least one sick injured animal or one dead animal is recorded, then is when the other attributes associated with health become available or enabled in their screen. In this case, the condition of dead animals, anomalies in dead animals, and potential cause of death. The anomalies on dead animals are symptoms or anything that they might report that is not normal for a carcass that they find. So let's say it's missing one leg or something very obvious. And I'm showing the list that we provide to them on the right. The potential cause of death is best guess of what they think caused the death of a specific of the individuals reported. And we also have a list of potential causes there that I'm showing here, but it includes if the animals are drowned or entangled, or if they are associated with fishing gear, etc. So for the past 3 years, we have completed this process in protected areas in Guatemala, in Peru, Madagascar, and Cambodia. And as you can see, obviously, all of these countries have their specific primary language, and the form has been translated into the local language, and then, as I mentioned before, inserted in the corresponding language. Once, as I mentioned before, once the form is established and inserted in the local questionnaires, we do have trainings that involve the local partners that then are going to go and train the rangers for start identifying these wildlife morbidity mortality events and use the attributes that we are providing to start recording these individuals. These are some of the results in picture, of course. These are data that the recording of this data would have been completely skipped if it wasn't because we have worked to actually make the integration and make the understanding that health data is important not only from the zoonotic perspective, but also as part of the goals that a conservation area management should have. And I'm showing here this track because actually the cell phone, what it does is it keeps the track of what the rangers, of the route of the rangers, meaning that we do have an effort associated with the findings, and then each one of these findings is associated with a specific latitude, longitude. One of the things that we have done recently is to start providing tools after the data has been collected for some time to actually get quick summaries at the local level. So SMART, for example, allows to run R scripts, and it's a great thing because actually what we have here is a HTML dashboard that can be created every time that one person that has access to that database wants to do it, and then, for example, distribute this among the rangers or with other authorities. Of course, as you can see, it's in the local language, but the thing is, the users of the countries might not be necessarily comfortable with R. Actually, the user that regenerated this report, she's not comfortable with R, but from SMART, she's just able to just run the script and get this output in a specific folder. What I'm showing here, of course, is as you can see, is the number of individuals that are dead or sick found per week. On the left side, on the right side, I'm sorry, is the spatial distribution of those events. And in the bottom is the species that have been found with that event. So once, I think it was around this point, once one of the points is clicked on, I get information on what's the number of the species for that week. I'm sorry, the number of individuals for that week of dead and sick individuals, the species involved and the number of individuals involved, that's in the bottom. And on to the left and to the right, I see the distribution of the animals on a space. Trying to get out of here. Okay. So far, in the general results are that we are covering so far 51 protected areas in 4 countries. More than 250 rangers have been trained. The whole process from the generation of the standardized Smart for Health form has involved 6 languages, and today more than 1,000 events have been recorded. Now, if you want to have more details, there is this preprint that is currently under second rounds of review. But we provide all the details of the process with all our partners from 4 countries and there. One of the things that I wanted to mention finally, because it was just 10 minutes that I have, it's that WCS, the Wildlife Conservation Society, is uniquely positioned to actually expand this approach on a global level because we are working in more than 55 countries. We are actually having this experience that we have gained for the past 3 years. And also because we have a health program that has been historical. We are the only NGO that has a health program and that has lasted for more than for about 30 years. And with that, I'm going to leave the space to Paulo, who is going to go deep into the experience that he has had integrating rangers across Peru on a national scale, which is a different perspective compared to Guatemala, where we're only working on Reserva Maya. In Madagascar, we're working in 2 protected areas, and in Cambodia, we're working in 2 protected areas. However, we are very likely to receive funding to expand to 5 next year. Thank you.
Thank you very much, Diego, for this very complete overview. So, Paulo, the floor is yours. Just to say that you have 10 minutes to then save time for question. Thank you so much. The floor is yours.
Thank you. Hello, everyone. So as Diego told, I will give you an approach how we are working here in Peru in the protected areas, doing wildlife health surveillance. So Peru is a biodiverse country, and is in the past decade is having a lot of wildlife health events. Some of them are infectious. We have mange in vicuñas, for example. We have cases that are not resolved, and we don't know what was the cause of it. Like in 2012, we had a mass stranding of dolphins in the coast of Peru. And in 2022, we had a big outbreak of avian influenza in the coast of Peru that have depleted the populations of seabirds. So with this background on wildlife health events happening in the protected areas and outside of the protected areas, we start bridging the existing capacities that are in the country to try to start building with another stakeholders, the surveillance systems in Peru. And for that, we have been working with CERNAM, that is the National Service for Protected Areas, and they have, they covered the 22% of the territory of Peru in protected areas, And they have human resources on those areas, more than 900 park rangers working in the field. And they have been doing surveillance with patrols using SMART to record any activity, human activities inside of the protected areas for more than 10 years. So that gave us the opportunity to start inserting some data models that could record wildlife health events in protected areas. So that way we had early detection of any disease can cause problems in human and public health or in other sectors. So with this background, we start enhancing the capacities, because we know like park rangers were using the SMART, they know how to do the patrols, but we wanted to add another layer of it that was like how to record if you see a dead animal or a sick animal, how to record that. And we did it in different levels first with different workshops. And this is important because first you have to talk, because it's a national level, we have to talk about concepts and the planning to how to implement it in a central level. Then it's important to train trainers, so that way they know the methodologies of it, they can share the information they have and train other people, and how are the processes of recording and reporting these events. And finally, and probably most important, training and workshops for the park rangers and specialists. And this information for them is more practical. It's a practical knowledge because they do a lot of things in the field. They are patrolling not only for health events, but mainly for human activities that is going on in the protected areas to prevent them. So, and the trainings and the workshops, the information we are sharing with them is about One Health approach. So all this information about health for park rangers is new for them, or for most of the people there, no? So we start like talking about what is the One Health approach, what that means, and we start like talking about wildlife health events, how to recognize, how to see them, what are the wildlife diseases, because it's a common knowledge that wildlife doesn't get sick, and how those animals can affect people, and they can carry some zoonotic diseases too, no? Uh, Also, after that, is how to record the data from the field and how to communicate it, no? Because if we have the technology also to implement it, there is a lot of training for that, no? And we train them also for the use of technology of smart. If they have been working for 10 years with this tool, even that, it needs to be continuous training, because people can forget how to record data from the field, no? Also important because all of this works happens meanwhile the avian influenza outbreak was happening in Peru, and it affected a lot of protected areas. Biosecurity was a key training, and also how they can coordinate with different institutions, no? Because the National Service for Protected Areas is not in charge of animal health. There are other sectors on that, so they have to share the information so the other sectors can come and take samples and see what are the diseases that are happening, no? So, and we also during these 2 years, almost three, we have been adapting the data model, because we came with a data model that was a broad one, and we give it to the park rangers to do it, to use it in the field and see how it feels, no? And if it's possible to record everything we were asking, and there was a feedback with them. So in that way, with each training that we were having, we were having feedback from the park rangers, what were they able to do in the field and what not. So that way we adapt the data model to have the information needed to have a response to any wildlife health event that could be important for public health. And also, this data model is adapted to the needs and the possibilities of the park rangers in the field, no? So that way we merge these two ideas. And this is super important because even if we are working with technologies, I know like probably most of us are professionals. Park rangers is a diverse group. So you have people that just have high school, some of them not, and you have also professionals. So it's important to talk to them and hear what are the necessities and how they work in the field also, no? Uh, to stop clashing and being able to leverage in what they are doing. So in the results, since 2022, we have had more than 14 workshops. There is more than 45 protected areas that have been trained, and there is more than 140 trained staff. Most of them are park rangers, but there is a lot of specialists also, and managers. And we have been able to integrate the data model that I had, and we include health events. So we have records a lot of species during this time. And here you can see some maps. What are the concentrations of wildlife health events? For example, in the first map in your left hand, we have recorded some dead monkeys also, and some birds, no? And here we can see how across the different years, there is a difference of a recording of events on birds, especially in the coast of Peru, because we were in this outbreak of avian influenza. Where are we now? We are working in the data center, because all this information is coming to the data center, but we need to work in the server to be able to manage the data and analyze it in an easier way, and being able to share it also with another sectors. As you can see, there is this dashboard from the Minister of Health of Peru that they were recording and bringing all the information from different sectors during the avian influenza outbreak to know where this disease was. So that way they can be aware and give an alert if some people were getting sick with these symptoms, no, of the disease. And this is a work of, you need a lot of time to do it, no? And we find some challenges. There is no wildlife health roles really in the country, so you have to work multi-sectoral for that. There is some resistance to integrate the wildlife health surveillance, and there is a lack or there's a lack of resources, no human resources, infrastructure, logistics, and the geography is difficult, and also the financial support that is super important. And the key learnings that we have from this work that we have been doing is we need to adapt the technologies to each reality. I understand that we need some standardized data, but also to being able to apply these technologies in the field is you have to see the realities of each protected area, of each area, no? Also, for the training, it's important not just give a presentation as we are used to. So there is a lot of methodologies for adult learning. So that way, people during the trainings, they have to think. So they are sharing the information that they already have to start building what we want, no? Also, it is important and continuous training, and it will have to be like that. It's not just one training. It needed multi-sectoral collaboration. It's a catalyst to improve things, and that happened in Peru, thanks, and not thanks to the avian influenza, but the multi-sectoral collaboration happens. So we leverage on these outbreaks, no, that involve all these sectors. So also the implementation is resource dependent. You have and you have to do the training to the different levels and know that, and also leverage on the skills that you have in the field, the people that you have, the talents and the resources available, no, and be flexible to that. And thank you.
Thank you very much, Paulo, for this practical example of implementation in a country, and it was very nice to see the key learnings and the challenges. And I think it would be nice to share that with a lot of countries. So now we have 10 minutes for the questions. We had some in the Q&A box. So the first one was on the list of indicators used for this integrated surveillance systems according to different sectors. What kind of indicators are monitored? So I don't know who want to reply to that. I know that Diego and Paulo, you mentioned some indicators on wildlife. Maybe you, Karen, and Rado can develop more on your community-based integrated system. What kind of indicators did you use?
Radu, would you like to speak about the list of indicators that the community health workers and people are reporting on, or would you like me to take that question?
Yeah, I can answer the question. Thank you, Imran, for the question. There are, as we told during the presentation, there are 12 priority alerts that we agreed through all the stakeholders. For community health workers, there are 5 of them according to human health. So the first one is the occurrence of any sign or symptom, non-common symptom in a cluster of person and within the same locality in a defined time period. There is also a clustered death of person in the same community and in 1 week or a few time period. What is bite or scratch of animal on human, even some missing children at school, which could be interpreted, but no, and also non-common travel of population from a community to another one, from village to another one. And all of these are mostly kind of generic, but in the reporting app there is space to provide details, and also through the information circuit, the community health care is expected to send the alert first, but after that, at the primary healthcare center, the head of the primary healthcare center, which is the first supervisor of these community health workers, have to call the community health worker who reported the alert to verify and ask for more detailed information if needed. Then all of this information go to the district health authorities for validation of the alert, and according to an existing algorithm in terms of risk assessment, the district health authorities decide about the response that needs to be conducted, and district health authorities also inform through the information circuit, the regional and central level for database need. And we are also of course, we say that it's a pilot study at the district level, but we are expecting in the future to be able to extend the use of this application at the national scale. So at this time, there will be more enforcement of all the health system levels.
Thank you so much for this review of indicators. So I'm seeing that some questions have been answered directly in the Q&A. We have do you have any option for cluster identification and investigation for any early warning for potential outbreak? So I guess this is more also on the integrated surveillance system.
When
I can take that
you,
one.
yeah, go ahead.
Oh, no, sorry, please, Rado, go ahead. I can complement later after, yes.
So when you ask about cluster, the possibility of cluster identification, do you mean geographical location of these cases,
I think so.
the alert?
I think so. Yeah. Well, it's how I understood that, but
yeah.
yes,
No,
geographical.
we haven't been included this option in the application, but it's a good suggestion to be considered. Thank you.
Diego, do you want to add on that?
Yeah, so from the data coming from the rangers, we are expecting to generate or accumulate more information to actually start developing those ideas of clusters, detection of anomalies in temporal trends associated with a specific species or a specific or the total number of individuals, identification of spatiotemporal clusters for epidemics, but also anomalies, temporal anomalies associated with chronic let's say, not so evident changes in that we could detect with morbidity and mortality. But yeah, we are absolutely thinking on that. For now, what we are doing, though, is to establish scenarios for ourselves. For example, if we find there are two animals, different thresholds, right? Different thresholds that should trigger different responses. Let's say, if the rangers report 3 dead animals of the same species in one spot, that should trigger at least one investigation or check what is going on. If you find 10 animals of different species at the same spot as well, if you find 5 animals of the same species that are dead in a span of 2 weeks, my bet would be that also that needs to be checked. So because in protected areas, although we do find cases, and thanks to a ranger we're accumulating this information, it's not common to find carcasses or sick injured individuals. And therefore, it's associated more with what are the anomalies in respect to those recordings.
Thank you very much for this response. So we have more questions and only 3 minutes left. So I will try to pick one. I'm seeing there is a question about the integration issue for both community and wildlife surveillance. And so what do you think should be the common integration point in the healthcare system? And in practice, how efficient is this? How long and how well does information get communicated across both community and wildlife system? Not an easy one, maybe. It's more about on your experience on integrating all the information from the wildlife surveillance and the community and how they are integrated, and then the information is, I think, going to the healthcare system. How well is the link is done, and what should be improved if it's not well done, according to your experience?
So I can answer from my perspective in Peru when we had the avian influenza outbreak. First, what the Ministry of Health did was know what the stakeholders were, from where the information could come. And we have the protected areas information that was being recorded. So that information was sent. And this is probably it's not that technological, no? Just send an email with all the information and all the data every week. So it's to improve the communication, and also the information were coming from the governmental sectors, no? They have the public health sectors and all the hospitals across the country. They have the agricultural sector that was recording some events in different places. So all the information that came from the birds, like domestic birds, were bringing to this platform, and and also the protected areas and the wild animal health outside of protected areas. So all of that information was bring to one sector that was the public health, and they did a dashboard with that, no? And the information they needed was how many birds were dead, because not all of them were diagnosed with avian influenza, no? I don't know if that responds the question, but
yeah, I think though that's giving quite clues on the difficulties on this kind of integrated system. So We are now coming at the end of the webinar. So sorry, because we have so many more things. We would have so many more things to discuss. I think that's was just probably a first introductory webinar on what kind of tools and what kind of approaches are existing. But yeah, it's raising a lot of questions in terms of feasibility, cost effectiveness analysis, and of course, we are deploying this kind of solution in a lot of countries. So hopefully in maybe 2 or 3 years, we have more to share and we will do that again. And so thank you so much to our 4 experts for sharing your experience. It was very nice, very clear. And thank you to all for your participation, questions, and for your for listening us. And yeah, I think that's my final word. Thank you so much.